Good afternoon to everyone, and welcome to this important session. So, for a long time, communicable and non-communicable disease were like a railway track. They were going parallel, never meeting. But the COVID pandemic actually changed that thinking and that paradigm. Although many of us cardiologists knew that there was an interaction between communicable and non-communicable diseases, but the COVID pandemic accentuated that relationship, and we now have a better understanding of the interaction between infectious diseases and cardiovascular disease or non-communicable diseases. For example, a few years back, there was an article published in the New England Journal of Medicine which showed that many patients of myocardial infarction had a previous episode of influenza. And when they looked at what was the risk, it was 6 times higher. If you had an influenza episode, the risk of having an MI was 6 times higher. Similarly, we learned from the COVID pandemic that the death rates was almost 3 times higher if you had a cardiovascular disease or a risk factor, as opposed to not having cardiovascular disease or not having any risk factor. So clearly, there are pathways by which both of them act together. There are mechanisms by which they accentuate the risk for each other, and so it's kind of bidirectional. In today's meeting or today's discussion, we are going to discuss this relationship, and we're also looking at a Venn diagram of cardiovascular disease, chronic disease, infections, and a bit of climate change, which has not been part of the concept, but that also contributes to the increased risk for cardiovascular disease. But mostly we'll be talking about the relationship of infectious disease and cardiovascular disease. So we have an eminent panel here. On my left is Professor Karen Sliver, from University of Cape Town, and a former president of the World Heart Federation. On my right is Dr. Kavita Singh. She's an epidemiologist and is from University of Heidelberg, and also partly works with us at the Center for Chronic Disease Control. And we also have Dr. Selberg. He's a physician, an internal medicine physician, and I think he's most eminently suited to talk about this topic more than cardiologists like Karen and me. So you're the most eminent here, really. Okay. So with this background, let me first kickstart this discussion. Professor Karen Sliver led a study for the WHF on COVID-19, and this study was conducted in almost 23 countries, recruited 5,313 patients to be exact, and we followed them up over a year. I just want you to summarize key findings from this study and what do we learn from this study.
I have the microphone. Thank you. Hello, everybody. So perhaps it's an informal setup, so you get an informal background of the study. So 2000, and the years are passing, 2019, and then early 20, COVID started, and I was president of the World Heart Federation, and suddenly, you remember all very well, so everything was closed, no more meeting, a lockdown, and we all didn't know what will come. And at that point, we decided it would be really an important opportunity to see. We knew from the history that certain viruses can have an effect on the heart. But in 2020, we didn't know if COVID-19 would be like a Coxsackie virus, parvovirus, having an effect on the heart, like leading to myocarditis, leading to heart failure. So we, and that really means us and Kalyani and Pablo Perel, who sits here, decided, and Lana, obviously, we decided it would be really a fantastic opportunity to understand from the beginning if COVID-19 has a particular impact on the heart, is leading to endothelial changes and new heart conditions. And we did one study which was on 5,000 patients from the first wave, which was, as you all will remember, the Delta COVID strain. And that was published about 2 years ago. And that created a lot of interest. And then we received, actually with very much by Andrea Vaselotti and discussion by others and with the WHO, asked us if we would not consider a long-term follow-up study. And that is actually what I'm speaking about. That started in 2000. We recruited patients from 2022 to 23. You might remember that this COVID strain has changed by the dominant strain had changed by that time. So we had Delta, we had Beta, and then came Omicron. And this is one of relatively few studies who systematically looked at the effect of a COVID Omicron strain on people admitted due to COVID-19. So we basically used the network we had created via the World Heart Federation of member countries who are interested in participating in this trial, and then invited people to join. And it was a very complicated and detailed questionnaire investigating what type of strain was tested, what vaccine was given at that time. Remember, vaccination didn't exist, so we had that information on vaccination. But we also had, could take some questions, or most of the questions were actually taken from the World Health Organization. We adapted some and went more in depth into cardiovascular disease. And then we looked, what are the dominant findings? And we looked at 1 month, at 3, 6 months, and then at 9 to 12 months interval. So what we found is that a substantial portion of the patient remained with symptoms beyond a month being admitted for COVID-19. It was interesting to see that 59% had the COVID test, and they virtually all had Omicron. About 60% of the patients were from low to middle income countries, and the rest from higher income countries. We found that we haven't analyzed, but the data will be presented by Dr. Kavita Singh on Sunday morning in a poster, the different types of vaccine we had and if that has an effect. So you have to come to a poster presentation. And then we looked at who ended up with what kind of symptoms afterwards. So I have to look, I just want to highlight, there is a paper which was published about 1 month ago. It's in Global Heart, the journal from the World Heart Federation. And you can obviously see the information more in depth. But we had, after we had over half of the patient, 56% experienced at least one major long COVID symptoms like fatigue, breathlessness, anxiety, chest pain, palpitation at 1 month. 1/4 reported persistent long COVID symptoms 9 to 12 months. And on the EQ5D scale, about half have difficulties in their usual activities. 23% had still after 9 to 12 months issues with mobility. What was also important, we looked at what type of new onset diseases people had, and we found, which was also confirmed in other studies, a high percentage of pulmonary embolus. It was 8%. If you look at the people 1 year later. Chronic kidney disease 4%, hypertension 3%. And also what was surprising to us, we all thought Omicron is really a mild strain, especially if you're vaccinated. No, we found that there was a total mortality of 15% at 1 year after post-discharge. So, and long COVID symptoms were more profound in female and people with risk factors like hypertension, diabetes, and if you're older. So we concluded that the study showed a substantial burden of mortality, morbidity, and 1/4 of the patients reported at least one persistent long COVID symptoms after 1 year. And we highlighted that early identification also for next pandemic, which might come, is highly important in how to act. And also, it's not part of the paper, but I think to be sympathetic for patients who still have symptoms after a prolonged period of time, I think that's also for me was one of the key lessons. Thanks.
Thank you, Karen. I think one of the important points about this study, apart from all the findings that we've had, is this study was conducted for the first time in many centers. They were conducted largely in low-income countries and low-middle-income countries. And it was done in a very meticulous fashion, despite the difficulties many of these centers had. Some of the centers did not have an ECG machine, they had to be provided one. So we went through a very difficult patch, but despite that, the study came out with the highest quality with almost 90% follow-up rate. Fantastic study. And I think I would attribute the success of this study to these four powerful women controlling these two men. And they just really, and Lana and Kalyani, who was not here, actually looking at every minute detail, and Kavita and Karen guiding them. And we were like, some spice in the curry. So anyway, jokes apart, we did a great job of this study. Right? We'll come back to you, Karen, and I'll ask you a few more questions. But before that, I want to ask Kavita, how did COVID-19 pandemic expose the health system weakness in many of the low middle income countries? What are your reflections on that?
Thank you for this question. First, good afternoon, everyone, and thank you for joining. It's an absolute pleasure and honor to be part of this session today. So, as a cardiovascular disease epidemiologist and health systems researcher, I often say that COVID-19 didn't just, stress test our hearts. It stress tested even our health systems too. And I'm not sure which one came out weaker. Let me start with this question to all of you. During the pandemic, how many of you personally felt or had trouble accessing regular healthcare like medicines or even routine checkup during the pandemic? So this experience was multiplied multiple times over, particularly for patients with cardiovascular diseases in India. So in India, the pandemic actually cracked and it deepened or widened the cracks that we already had in the system, particularly for chronic care. We did a research in India across 4 different cities, 2 urban and 2 rural cities, and we found that during the pandemic, these patients who were living with chronic conditions, including hypertension, diabetes, and cardiovascular diseases, they didn't just struggle in terms of access to medicines and routine monitoring, but also the psychosocial stress and financial stress that they faced, which all contributed or even worsened their symptoms in terms of hypertension control or diabetes control. So one side of it, it did expose the health system challenges. But on the other side, I would also like to highlight some brighter sweet spots. In collaboration with a team based in Ludhiana, which is situated in a northern state in India, we pilot tested a nurse-led teleconsultation using pyramid model. And the study showed that when you train nurses to screen for COVID symptoms, and alongside, they can also help patients to better manage their hypertension and diabetes. In this study, only 5% of the patients required escalation to physician, and less than 1% required hospitalization. That was impressive. So if I'm allowed to make a joke, if doctors ever need vacation, in the study, nurses proved that they can run a clinic. So what did we learn? I think the lesson is very clear from the study and the experiences that we gained during the pandemic, that going forward, we need resilient and hybrid health systems or healthcare delivery models that combine digital health, telehealth, plus empowered frontline healthcare workers to maintain the continuity of care that is required in patients with chronic diseases like cardiovascular diseases, particularly during a time when hospitals are overwhelmed. Thank you.
Thank you, Kavita, for that reflection. And yes, there was a lot of issues with the health systems in many parts of the world, particularly in low middle income countries. And COVID really brought out all the inadequacies which you very well summarized. Now I go to Dr. Schellberg. Am I okay in terms of, okay, yeah. So you're a physician, you've been treating patients. Which are those patients who had the highest risk of complications, and what were the conditions associated with which increase the complication rates in patients with COVID?
So, well, first, thank you very much for inviting me to the session. I'm a bit of an outlier because I'm an infectious diseases specialist and GP, so I'm just acting from a different kind of perspective. And coming to your question, it appears to be easy, right? So when we think about cardiovascular consequences, we think of those people who are, well, I would call them the usual suspects, right? We think of diabetes, we think of aging, we think of frailty, we think of obesity. the problem, and that's actually what we learned, is because in the beginning, what did we thought about? We thought about a respiratory tract infection. So we thought about asthma, COPD, and the course of disease easily showed us those are not the patients who have the highest risk. And I think what we learned actually from COVID-19 is that although we focused then later on those patients with cardiovascular risk factors, those are not necessarily those patients who will actually experience those cardiovascular sequelae afterwards. And I think we are still in a position where we are not entirely sure. So when I go to my colleagues who are, whatever, somewhere in a rural area and say, well, you need to take care of your patients with cardiovascular diseases and heart failure, it's just a part of the story, right? Because there may be a group of patients who are at significant risk, as we have seen in the Cartesian study just recently, where we have no real good tools in our hands to pre-identify them. And I think that's actually an issue, and that's something we need to work on, and that's why approaches like your ones are so fascinating, because they can teach us for the daily clinical practice, which I'm covering in my daily life.
Thank you. So coming back to you, Karen, you mentioned a little bit about long-term complications. Any reflections on myocarditis, heart failure, or any other cardiovascular condition post-COVID? What do you think? Does it really increase? I mean, there are a lot of people talking about sudden cardiac death post-COVID. So any thoughts on all of these?
Yes, I mean, I actually do a heart failure clinic in our hospital, and there were actually quite a number of colleagues, I mean physicians, who came to see me, and we didn't pick that up so much in the study, but I mean what was interesting is I saw really several, I counted 8, who had a pericardial effusion in mild systolic function. But obviously I think a study like that might not pick it up, but obviously if a colleague comes to me, says they're more tired, I really look with the echo. It's not profound, it's not dramatic impaired systolic function, but look, you feel not good. If your systolic function is about 45, 48, you're not terribly ill. But if you're usually fine, you're 35 years old and usually fine and have one of 60, I guess you feel it. So I saw a number of colleagues, and some it was interesting. One I remember in particular well. She is a public health doctor, and she had the Delta strain and had a pericardial effusion, and then 1.5 years later she came back with, in between the effusion was gone, and then she came back with an Omicron infection, despite being vaccinated, and had again a pericardial effusion, again systolic impaired function, but it also recovered, but took quite some time, and she actually is working half day now. So that was my personal experience from seeing colleagues.
So what would you attribute these complications to? Like, is it direct affliction of COVID-19 on the heart? Is it sequelae of the treatment? Or is it the pre-existing heart disease got unraveled because of the infection? What do you really think was happening as to why these complications? In fact, you mentioned something like 17% death by the end of 1 year. That's huge. I mean, post-myocardial, even heart failure patients don't have that much mortality at 1 year. So clearly there's something more. So what do you think? Is it prothrombotic milieu which is causing, or is there myocarditis which weakened the heart leading to arrhythmias? What could be the reason?
I mean, I think the especially Omicron is for me an endothelial disease, and we clearly see an increase in thrombotic events. And what's interesting, we see late thrombotic events, which are clearly outside of the hospital phase. So I think a substantial proportion of the patients who have a sudden cardiac death, which was defined by death within 24 hours after being seen alive, is most likely due to pulmonary embolus. Very few have an autopsy, or strokes. And so I think that is an important factor, yeah.
Thank you. Coming to you, Kavita. I think for the last 10, 15 years, we have been talking of integrated care. We have been looking at interdisciplinary approaches in terms of managing diseases at the level of the health system. And the COVID pandemic gave us that kind of alarm or whatever in terms of providing an integrated care. So what do you really think the COVID pandemic has taught us in terms of implementation sciences and interdisciplinary approach for integrating care between infectious disease and cardiovascular diseases?
So from my own experiences, one big lesson or takeaway from this experience during the COVID pandemic is that silos don't work. In our research study, even patients have told us that they felt abandoned, during the time when infectious disease care took priority. And from implementation research experience, we know that context matters more than content. In our research study, when we co-designed these strategies, including patients felt they were seen and they were supported. For example, we integrated blood pressure monitoring alongside the COVID care pathways, and this provided additional support during the pandemic to these patients. Plus, I think integration of different health services should be intentional and it should not be an afterthought. And what we need for building, these resilient and integrated healthcare system is also interoperability, like data which can operate across systems or across disciplines. Like infectious disease data can also speak to cardiovascular disease or chronic or other chronic conditions. So therefore, I want to emphasize that integration should always be intentional and well planned to optimize the already constrained healthcare resources that we have. I always wonder that we have seen that during the pandemic that if viruses are not respecting boundaries, then why should our health services should? So we must definitely expand and integrate different health services and bring together different disciplines together to provide better care for patients so that they don't feel abandoned or neglected during these crisis time.
Thank you. I mean, that was quite an eloquent answer. So, Dr. Shelberg, what I want to ask you is, as a physician, when you get these infectious diseases like influenza or COVID, do you specifically look for cardiovascular risk factors? And if they are present, how do you manage them? Or do you think that you would ask for hospitalization if they have severe risk factors or severe cardiovascular disease? Or would you manage them out at an outpatient basis because the health systems are quite overloaded in most parts of the world? What do you really do?
Well, I think it's very, what you said last is very important because it's very difficult to make a general statement on that one because healthcare systems look totally different. But what we learned from infectious diseases, or what we can learn from infectious diseases, is that the window of opportunity we have in a viral condition is very small and very, very, very short. So I think the best answer to your question is, what do you do? How do you do it? Do you screen? I think the most important answer is not what to do, but when to do. And actually, when the patients have their first symptoms, it's most likely already too late. Looking into the healthcare structure. So who's going to see the patients, if at all? It's probably the nurse, it's the caregiver, it's probably the GP, but definitely not the cardiologist, not the pneumologist. So I think what we need to do, and that's really, we need to be vigilant here, is we need to inform the patients that if they have a problem, they qualify for additional care. So we need to do that beforehand. When we expect that in a condition like COVID-19, we have sufficient time to do that, everybody knows everything happens on a Friday afternoon. And on Monday, it's too late. Yeah, and I think that's exactly when the acute embolism already happened. That's exactly when the patient already has been hospitalized. And I think we cannot wait for that. And that's something we knew. It's nothing new. We have the same effect in flu. We have the same effect in EBV or CMV, whatever. That's something which is known. I think what is important to us, and here I think we can work together again to communicate this knowledge. To tell the late GP somewhere out there, that from the flu, they don't die of the respiratory tract infection. They die of the stroke. Well, we just have seen that with the former Pope. He had a respiratory infection. Nobody knows which one, but what did he die of 3 weeks later? Of a stroke. We need to use such kind of examples to pre-identify the patients to make sure that an integrated care system, however it looks like in rural India or in the metropolis of Berlin, we need to make sure we use the resources in a clever way and in an early way to provide the most appropriate care to those patients who are at the highest need.
Thank you. So that actually is a good segue to the next question to you, Karen. Based on your experience in this study, how do you think care should be integrated, and are there differences in multiple health systems that we did this study? How do we contextualize this integrated care in terms of managing patients with an infectious disease and a chronic disease that coexist with each other?
I mean, I think that will be different across different health systems, so it depends where you're working. But I can just tell in Africa we have a program, it's called the PEN Plus system, which is, I think it's also in some countries beyond Africa, but it's largely in Africa. And that is basically a model. I mean, Jean Bookman from Harvard was fundamentally involved, started in Rwanda, then it's expanded to Mozambique. It's now in other African countries and going, I think it's now in Pakistan, if I'm not wrong. And the principle is really, it started with the HIV crisis and pandemic we are still facing, but also now the increasing burden of hypertension, diabetes, and obviously other infectious diseases like viruses. And there is actually a very nice program now which integrates that you might have HIV, but it doesn't mean you're not getting obese and hypertensive heart disease, and how you in the same clinic where you get your HIV treatment, you get once a year your blood pressure measured and your weight taken. It sounds so basic, but there are lots of people globally who don't have a scale, who don't know they're obese, where you create awareness. So I think I can only talk about, let's say, that program, which is relatively cheap, using existing infrastructure for HIV/AIDS, and integrating basically the ever much growing burden of cardiovascular disease, in particular hypertension, which is in some African countries like Nigeria now the really predominant threat to the population. So I can't speak how it would be suitable, let's say, in Europe, but I think in most part of the world, an integration of certain services would definitely save time for the nurses, for the patient, so for the physician, for the entire system. It saves cost. And I think most of you will be aware that even in quite affluent countries, there is a marked increase in healthcare cost, and most countries struggle with that. There is a small part of the population who sort of has all, but this is not the vulnerable population. This is not the population which is obese and get early strokes. So there is definitely in all population, including Switzerland and Germany, you will have a certain part of the population, those are who getting the compilation, who will definitely benefit with a more integrated approach dealing with preventive medicine.
Thank you. So Kavita, just going back to the same thing, how do you think the countries should organize their healthcare systems in terms of integrating? There are many ways of doing it, but what are the few areas which I would say are the low-hanging fruit, which people can use in terms of integrated care? How do we harness technology to help us?
I think my approach would be to, I would refer to the WHO Health Systems Performance Assessment Framework. To have and to build, integrated care systems, we need to work across all functions of the health system. We need to strengthen not just the service delivery, but also focus on health workforce, resource generation, healthcare financing, and also have like institutions or leadership or governance in place. So if we focus and intervene across all the 4 functions of the health system, it's proven that it can produce the intermediate goals or the ultimate goals of the universal healthcare coverage. We don't have, I would say, a blueprint ready, or it's not easy to answer. But from my perspective, I think we need to bridge the community care with the primary care, and more strengthening is required at the primary care level, where there have been successful pilot programs and examples from Africa, Asia, where in our own study, like that was led by Dr. Prabhakaran, we have demonstrated that when you train nurses and when you can provide them and empower them with the clinical decision support system, they can better manage hypertension and diabetes at the primary care level. And this further reduces the system's burden at the higher level facilities like secondary and tertiary care facilities. Yeah. And plus, I think there can also be a need for patient navigation because in most LMIC systems, I think healthcare systems are quite complex and patients do not really know where to seek care for, and the referral care pathways are really poor. So there can be a role of patient navigators or patient navigation tools which can further strengthen both on the demand side as well as the health system level structural issues in terms of providing care and timely care for these patients.
Okay, thank you. So, Dr. Schwelberg, in your own experience, has the COVID pandemic resulted in major changes in terms of treatment protocols or in terms of how we modified our practice to address this complexity that we have understood now because of the multiple problems that an individual could have, both chronic disease and infectious disease? Has it resulted in any change in your protocol in primary care or in your hospital?
Well, I wish my answer would be yes. So we did that, but I think to be, critical enough, I think right now what we see is just the opposite. And I think we are still facing this kind of, COVID fatigue, also in the healthcare profession, or probably predominantly the healthcare professionals. So they don't want to hear about it anymore. They don't want to see vaccinations anymore. They don't want to discuss about treatments anymore. In a way, we are in a very good situation, in a good position. We have loads of data. COVID-19 has also shown us to look into our healthcare systems again, which we didn't do over years. We have treatments, we have prevention, we have everything in our hands. However, right now we are in a situation of, I would say, it's a global neglect kind of thing. So we're not doing anything. And if you ask me, okay, the next pandemic, would we do any better? Probably not. We would definitely not. So I think what is very, very important is we need to use the data we have. We need to use the tools we have in order to tell the right people. And you nicely said it's probably the lower level of the healthcare system. It's the GPs, or depending on the healthcare system, it's the nurses, it's the community helpers, to teach them, well, it's not just to identify something, but you can make a difference. There's something we can do. So we should not stay silent about COVID-19 anymore because people are bored of it. They won't want to hear it anymore. They don't want to see it anymore. I think it's our objective, really, to integrate the care, as you said, and to say, well, let's, the cardiovascular specialists, the GPs, the infectious diseases specialists, to work together because we have the tools in our hands. The only thing we need is actually using them. And we should not forget to involve our patients. Because, when I talk to my patients, and we talked about identification earlier, I love to say, whom of us would love to hear from the physician, you are at risk? Nobody wants to hear that. You're at risk having stroke, or you're at risk having a diabetes because your grandma had. And who wants to be at risk? But if you communicate in a way to tell the people you qualify for treatment, you qualify for a prevention, and you qualify for specific care, that's a totally different way to do that, to have this positive thing in there. And from an HCP perspective, to say, well, there's something I can do. I have a role in there, and I think that's actually what we need to do. Have we gone there? No, we haven't. But I think we need to use opportunities like this actually to get it started.
Thank you very much. I think that was a very useful, practical suggestion in terms of what we should do. And hopefully people have heard about what you said and kind of utilize these suggestions. I think this has been a super efficient panel. You answered to the point. You didn't digress. You didn't, dilate whatever you wanted to say. So we are almost at, within 35 minutes, we are at completing the panel, but I would open up for questions from the audience if there are any. Please feel free to ask. Something which we have missed, maybe? No.
Hello? Oh, no, now it's working. Thank you. Thank you for the interesting conversation, and maybe I would like to follow what was your last question to Dr. Schellenberg, but maybe for India and for South Africa, and for the cardiovascular community. First, after COVID, there was a lot of interest immediately. Are we still in the cardiovascular community did we keep that interest between cardiovascular disease and infectious disease more generally? Did it change and it's sustainable over time? And are we better prepared for another pandemic, let's say in India and in South Africa?
I think there's more interest. I mean, if you look at recent review papers, seminar papers, invited papers, you see really in all the leading journals, if I just do journal scan in my head, you see a number of reviews. I just reviewed actually a paper on HIV and the heart. It's not published. I'm not sure if it will be accepted. I liked it. So there is clearly more interest from the journal editor and I think the general community on the intersection of communicable and non-communicable disease. In South Africa, I can say there's dedicated funding for projects intersection of infectious and non-infectious disease from a South African Medical Research Council. So clearly in South Africa there is more money invested into that aspect. So I think, yeah, I would say yes. The second question you asked if we would do something different.
Well, I think in South Africa, you think it's
Yes.
better prepared.
Yes,
particularly for the people with cardiovascular disease.
Yes, I think it is. I think it is better prepared from two aspects. I mean, one thing which was not well recognized initially, but is now recognized, is really the burnout factor for nurses and physicians who are in the system in a pandemic, and it can be anyone. And I think that's really something which then got attention. Was difficult to manage, but I think if we get another similar situation, I think it would be better managed. And we had a number of, especially anesthetists, actually leaving the field. I mean, because we're not used to have so many people dying. Remember, anesthetists usually don't die in an anesthetic, but suddenly they were in the direct care involved of patients who didn't make it, and there was a lot of serious mental breakdown and leaving the field totally. So I think that people would focus on trying to avoid. It's very expensive to train physicians and nurses, so that's one change. I think South Africa learned relatively fast that a total lockdown is not good for the country, not good for the economy, and will not totally avoid the problem. So I don't think South Africa would go into any type of dramatic lockdown if we would have a different virus strain, so that's one of the lessons. And I think South Africa also developed relatively early the testing of COVID in sewage water. It was one of the first countries who implemented that. So instead of testing population-wide, which is quite costly and uses your resources, I think they would focus on testing, spot testing in certain system, the sewage system, and then you learn and translate directly into practice.
So I think it's not that easy to answer about India. It's a huge country with a lot of heterogeneity in care. Healthcare is a state subject, and I just wanted to quote two of the most famous authors who have written about India. V.S. Naipaul, who was a famous author, said, "India is full of million mutinies." So you can imagine that there are so many different things that happen. And second is, we are very argumentative. So, but despite all of that, despite the functioning anarchy that we are, few things emerged. Number one, there's a strong architecture built by the government of India on digital health. It's called Ayushman Bharat Digital Health Mission. So the whole infrastructure at the primary healthcare level is being digitized across the country. That's number one. Second, telemedicine has gained prominence, and that would be very helpful. Third, what we have learned is that total lockdown can be counterproductive. It may be helpful initially, but can be counterproductive in the long run. So decentralized lockdowns, asking local communities to look at protecting individuals is the third thing. The fourth thing is protecting vulnerable individuals, like the elderly, people with comorbid conditions, and there are mechanisms of how to do it. And the last is supply chain management to improve access to care, because the biggest hit during these big pandemics, is people don't get their medicines which are like insulin, for example. So clear-cut supply chain management of these drugs. So these are some of the things that have come to the fore, and obviously task shifting, which Kavita mentioned, integrated care, quality improvement, all of this would help. So we have learned our lessons, but it's a long way to go.
Something I would like to add, because there was a second part to your question, because it was how can we continue to integrate infectious diseases into cardiovascular care? And I think you cardiologists, if I may say so, you have an easy tool at your hand, because you are the guys who identify the risk factors. If you put into your physician's letters that this patient should, if anything can be done to prevent an infectious disease in this patient, get vaccinated, get treated early enough, because this is an integrated, isolated risk factor for a cardiovascular event, that would be very, very helpful. Because the situation we have right now is that we have a lot of GPs who are very, very reluctant to do anything about an early infection. You have heard all these discussions about drug-drug interactions. I'm not going to stop the statin because this puts risk at the patient, totally neglecting that a severe COVID-19 infection may be a much higher cardiovascular risk, but stopping the statin for 5 days, things like that. So I think you have a major role. You are the guys who please put into the letters, please make sure the patient doesn't suffer of an infectious condition. And I think that would be very, very helpful. And here again, HIV is a beautiful example. I'm treating a lot of patients living with HIV, and here we have integrated cardiovascular health because we learned our lessons out of the treatments. We learned that we have a continued vasculitis in these patients. We heard about vasculitis, exactly the same which is happening in COVID-19, so I think we can learn from that.
Right. Any more questions? Anyone? Okay, if there are no questions, maybe I'll give you 2 minutes, 1 minute, whatever you want to take to summarize whatever you're told, and any things, final things that you might have missed.
Oh, okay. I think it was a very good discussion. But I must say, perhaps from a personal level, I really enjoyed doing the study with the people who are here. And I think it was also, I hope the World Heart Federation will continue to doing some type of research. I mean, it is a fantastic opportunity to have so many member societies, countries, and I think a lot can be achieved by if the society pulled together in various aspects. First, to gain new information about a certain disease or risk. Secondly, you empower in those countries younger researchers to be part of a network, to learn how research is done. They learn to form their own study, hopefully. There will always be someone in the country who will learn and do their own thing. And even if there's one in the country, that's fantastic. So for me, this is one of the lessons from this particular project, that a lot can be done with limited funding, with enthusiasm, with weekly Thursday 12 to 1 phone call over a long period of time. And I learned a lot during the study.
Thank you. Kavita, your reflections.
It's very inspiring listening to you, and thank you so much to your leadership, Professor Sliver, Professor Prabhakaran, and Professor Perel. I would just like to sum up and say that our study, this long COVID or World Heart Federation long COVID study, provided strong evidence that, long COVID is also cardiovascular disease issue, because we found substantial, burden in terms of new onset hypertension, diabetes, and major adverse cardiovascular disease events, up to 17% cumulative at 9 to 12 months follow-up. And clearly, there are examples also that shows us that we need resilient and hybrid care delivery models that includes or combines digital tools, telehealth, and these shouldn't be just seen as emergency solutions. These are the future, right? I think patients deserve better healthcare system, a system that can not just walk, but also chew the system, right? Thank you.
Yeah, I can just add to that one. I think I would love to use the event today as a starting point. I think we started a great discussion, and we should keep the discussion going, really to have this integrated kind of approach, to discuss it, to challenge ourselves and to challenge others in the things we have learned and probably things we did differently. I think it's a very good sign that, you know, me being not a cardiologist, being here today, and I think we should use this as a starting point. And we probably actually can use COVID-19 as a good case example. Actually, how can we make things better, but that asks for us to challenge ourselves, to challenge what we have done and what's being done in the future.
So thank you very much, and that was a great discussion.
Yeah, sorry, just one thing. Just as Karen mentioned, the paper is in Global Heart and it's open access. So if you want to read the study, everyone can go into the Global Heart website and read the WHF COVID study.
Right. So it was a great discussion, and we brought out a lot of points, and the most important being that COVID-19 actually struck at the core of the health system, and what matters is really reimagining and redesigning the health system for future pandemics, and the central to that is integrated care, which all of us spoke about. And the second thing which Karen pointed out is the research capacity building that happened in multiple countries, and we should continue to use this. The World Heart Federation should think of commissioning more studies like this so that we continue with our process of capacity building across these countries. So with that, let me conclude this session. There are no more questions. Thank you all for being here and enthusiastically participating in this discussion. Thank you very much.